Okay, good afternoon, everybody. A warm welcome from my side and also from my co-chairman, Lars Sondergaard, to you, to this very interesting symposium we are having ahead here. You can see the program right away, and we are talking about TAVI, and we all together witnessed an unprecedented success story with TAVI starting in 2002, excuse me, and we have witnessed by now and experienced by now many iterations of the devices. And one very important milestone, of course, was also the release of the Lotus device in 2013 and the novel iteration of the Lotus device, the Lotus Edge device, which came to the market 2016 and which went off the market for some technical reason also in 2016, and as far as I know will return to the market hopefully very soon. So the Lotus clinical program, it has been very intensive and has accompanied the device implantation in the frame of the Reprise 1, 2, and 3 study, and we will learn during the session more novel insights about the Reprise 3 trial, very important trials who really put advantage to the patient care treated with TAVI. And fortunately enough, there is a next generation Lotus Edge device available or should be available very soon again. It maintains the benefit you're going to learn throughout the session about this of the first generation, so to say, classical Lotus device as the adaptive seal and the complete repositionability and the early valve function, which makes it a really calm procedure. The delivery system has been improved. It's not as bulky as it used to be. Trackability is better. The profile is a bit lower. And most importantly, the deployment was optimized due to the depth guards system. We don't have to dive as deep as in the early days in the left ventricular outflow tract, and this may inflict the pacemaker rate, as we will learn in a minute from now. Of course, the Lotus Edge device has also been accompanied by an intensive clinical program, as you can see and easily appreciate on that slide. And these trials have all been initiated, of course, by Boston Scientific, a scientifically working and investigating company, but there are many investigator-initiated trials in the frame of this study program with very interesting questions, for example, within the Notion trial, and we're going to learn about some of these data also during this symposium. So with no further ado, again, I would like to welcome you to this symposium, and I would like to call Ted Feldman to the podium. He's going to give us some more insights from the Reprise 3 trial. Please.
Thank you. Thanks very much. I am delighted to be able to talk about the results of the Reprise 3 pivotal trial. This was a large randomized trial that we presented at EuroPCR several months ago. And you've heard a little bit about the background of the Lotus device, but I want to highlight, in addition to repositionability and the fact that the valve has hemodynamic function early during deployment, that the distal half is covered with an adaptive seal designed to minimize paravalvular leak, and that design feature is important as part of the main endpoints of the trial. This was a large trial, 912 patients, randomized 2-to-1, Lotus compared to core valve. So, of course, a patient had to be suitable for both devices. All of the cases were reviewed by a case selection committee. And in terms of stroke adjudication, this trial is unique in requiring neurologist exams before and after the procedure, in contrast to most other trials that have required exams, but by people certified in NIH stroke scale, such as nurses, rather than neurology professionals. Baseline demographics are typical of a high-risk TAVR population. You can see a mean age of almost 83 years and a mean STS risk calculator score for mortality approaching 7. This gives you a picture of where this trial fits in the spectrum of high-risk trials with STS as one of our better objective measures of what a trial population is comprised of. This is the primary safety endpoint. This is the combined endpoint of death, stroke, major bleeding, kidney injury, and major vascular complications. And you can see that at every time point, there is no difference between these two devices, the first generation Lotus and the core valve device. A couple of other safety endpoints that are really important. You can see here that the overall pacing rate was 16% for core valve, 29%, significantly higher for Lotus. The relative difference is the same when you consider only pacemaker-naive patients. Another really important difference between the two devices, because the Lotus device is completely recapturable and repositionable, there were no instances of valve-in-valve or malpositioning. So 3% of patients in the core valve arm had a second valve and 2.6% valve malpositioning. In terms of the pacemaker endpoint, this gives you a snapshot of how this fits in perspective with other trials. You can see in the Reprise 3 trial, the 29% rate for the Lotus valve, 16% for the core valve. Importantly, the depth guard system, which is part of the second generation Lotus design in a 50-patient registry, showed an 18% pacemaker rate. And this is one of the design improvements that Georg just talked about that is really important in the next generation device. This shows the primary effectiveness endpoint for the combined endpoint of death, stroke, and moderate or more paravalvular leak at 1 year, and by either intention to treat or as treated analyses, the Lotus valve was superior to core valve for the combined endpoint, and this highlights the success of the adaptive seal of the Lotus device at virtually eliminating paravalvular leak. All-cause mortality was not different, as shown here. Mortality and stroke together were not statistically different, though numerically favorable for Lotus, and as you saw, mortality was the same, so this is driven by a lower stroke rate in the core valve group. This shows again in perspective the major and disabling stroke plus all-cause mortality to 1 year results across a variety of trials, and you can see that importantly the core valve results in the Reprise trial are similar to other core valve high-risk trials, and the Lotus outcome is as good or better. Here's the stroke results. The stroke results in the Lotus arm were at the low end of predicted and the core valve at the high end of predicted. This is probably play of chance. Several other endpoints that we saw that are important. One occurred with low frequency, and that is valve thrombosis, 9 patients, and these were asymptomatic patients detected by a rise in gradient at the 30-day echo, which we know now is a problem with all TAVR devices, but something that certainly we have to pay attention to going forward. And the other important difference in events at 1 year was a greater need for repeat procedures in the core valve group, again due to valve malpositioning. This slide highlights the difference in paravalvular leak, and the superiority of the primary endpoint was driven by a reduction in paravalvular leak with Lotus compared to core valve. Here you see moderate or severe PVL in 6.9% of the core valve patients, under 1% of the Lotus patients. I think the more important way to look at this is when a patient goes into the procedure, how likely are they to come out with none or trace or mild PVL? And you can see that that is 99% of patients who are treated with the Lotus device. And here you see this finding illustrated across trials, the frequency of none or trace, so not even counting mild, none or trace PVL 84% of the REPRISE 3 Lotus-treated patients, which is clearly an illustration of the success of the adaptive seal. This slide shows all of the large pivotal trials across trials, and I show this slide to highlight that in REPRISE 3, the core valve group did not have unusual outcomes, but rather their outcomes in a high-risk trial are in line with other high-risk trial TAVR results, and even in comparison to intermediate risk trial results are in line, and that the LOTUS results, and this is death and stroke alone, are really quite good. I want to show you a case that illustrates another strength of the core valve platform. This is a typical type of trial patient, a 90-year-old with an STS of almost 11%, clearly a high-risk patient. And the feature I want to illustrate is how the LOTUS platform performs in the setting of extreme calcification. Here you see the so-called saber-tooth or dagger-like calcium in the LV outflow tract. And this is a real serious problem in terms of cause for both PVL and risk of root rupture with the available valves approved in the United States. So the mechanical expansion of the LOTUS valve seems to be gradual and displace calcium in these cases really uneventfully. And this is pretty typical that we see in these extreme calcium cases favorable deployment and the same kind of absence of paravalvular leak that we see with LOTUS valve in less calcified cases. And this finding was illustrated in an abstract that Raj Makar presented earlier today in an analysis of calcium burden and its impact on outcome, low calcium burden versus high core valve compared to LOTUS. And what you see is that the calcium burden does make a difference for paravalvular leak in the core valve patients, but in the LOTUS patients, the presence or absence of heavy calcification has almost no impact with the same predictable absence of calcium burden. We're going to have another trial presented tomorrow, and this is going to be an impact of pacemaker implant on clinical outcomes from the REPRISE trial presented by Chris Maduri. That'll be tomorrow afternoon. So in summary, the REPRISE 3 randomized trial is the first large pivotal trial comparing two TAVR platforms. It showed non-inferiority for safety and superiority for effectiveness with virtually no significant paravalvular leak and fewer disabling strokes and repeat procedures. We did find small numbers, but more valve thrombosis. Importantly, a higher pacemaker rate that we anticipate will be mitigated by the next generation device. And I think this really highlights the features of the LOTUS platform. So there's I hope, a brief summary and I hope a meaningful comparison with where does this trial fit in the spectrum of reported results. Thank you.
Well, thank you, Ted. If there are no burning issues, we have a Q&A session at the end of the procedures. And we go on with Dr. Goldberg, and he's going to teach us about his clinical experience with LOTUS Edge. Oh, Dr. Wörler. But you changed also the topic, or?
No, it's just like in the
Okay.
program. So we want to show the data of the LOTUS Edge first prior to seeing some cases. So it's a great pleasure to present here data how the LOTUS Edge will improve and expand treatment options. I'm from Ulm University, which is in the south of Germany. So this is my conflict of interest. Got some research grants from Boston, Edwards, as well as Medtronic. So what will improve with the LOTUS Edge as compared to the classical LOTUS system? The delivery system will be more flexible. The sheath size will be reduced to 14 French for the 23 and 25 millimeter device and 15 French for the 27 millimeter device. In addition, we will get two other valve sizes, the 21 and most important, the 29mm valve size to treat more patients. Interestingly, the locking verification will be only one few due to the radiopaque markers. I will show you some pictures in a minute. And the deployment will be more controlled with a depth guard. I will show you what depth guard will do with the Lotus Edge implantation. Here you see that the catheter is more flexible, so we have a better coaxial alignment with an optimized pre-shape curve, and the profile is smaller, 3 to 4 French, as compared to the classical Lotus system. You see here that there are radiopaque markers, and with the radiopaque markers, you just need one view to be sure that the valve is completely locked. And in addition, the Lotus Edge comes with a depth guard, and the depth guard is important because with that we can better control the position of the Lotus valve in the LVOT. On the left side, you see the classical Lotus, a 25mm device. And by implantation, you see that the length of this 25mm classical Lotus device is more than 3 centimeters. So we have a lot of length of the frame of the Lotus valve which can interact with the aortic stenosis or can interact with the LVOT and have some interference with the conduction system. On the right side, you see the 25mm Lotus Edge system. And due to an early anchoring in the LVOT, the length of the frame which can interact with the LVOT is much shorter. So probably reducing the interaction with the conduction system and probably reducing the need for permanent pacemaker implantation. This animation shows you nicely on the left side the classical Lotus. By implanting the classical Lotus, you have a deep dive in the LVOT, then you release the valve, and then you shrink the height to its final size of 19mm. On the right side, you see the Lotus Edge, and the Lotus Edge is not so deeply diving into the LVOT. We have an early anchoring to its final size, and then the rest of the Lotus Edge is deployed, and you see here nicely these radiopaque markers, which gives you the opportunity to check the locking of the device within one view. So what do we believe will the Lotus Edge improve? So we do have some unmet needs with every valve type here present available. Of course, this is still paravalvular regurgitation. It's also conduction disturbances. Treating bicuspid anatomy is always challenging. You will see some cases in the next presentation. And of course, with every valve type, we have to talk about durability and valve thrombosis, especially if we go to younger patients or low-risk patients. So regarding paravalvular regurgitation, we do know that the present valve designs have improved compared to the first-generation devices. But there are still complex anatomies, such as bicuspid anatomies or severe calcifications, where it's still a challenge for sizing and positioning. We do know that severe PVL is associated with an increased mortality, and we do have excellent outcomes with the Lotus, as you have just seen by Ted Feldman. If we look into the data, moderate severe PVL with the Lotus and Lotus Edge at 30 days, it's only 0.3% in the RESPOND registry. It's 0.6% in REPRISE 3, and it was 0% in an early feasibility trial of the Lotus Edge, including 29 cases. And this is what we already know from the Lotus. This is based on the adaptive seal, which minimizes the distance between the stent frame and the LVOT, or the calcium in the LVOT. I would like to add some data from Ulm. In this analysis, we included more than 500 patients, so we have implanted about 300 Lotus valves so far. And in this analysis, we included the first 202 Lotus cases and did a propensity score matching with a balloon expandable Edwards Sapien 3. You can nicely see that the device success was similar, but of interest, the rate of even mild aortic regurgitation was lower with the Boston Scientific Lotus device. This was a p-value of 0.08, so this was a trend based on 404 propensity score-matched patients. And we followed those patients for up to 2 years, and you see that the disabling stroke-free survival was similar. In red, the curve for the balloon expandable Edwards Sapien 3, and here in black, the curve for the Boston Scientific Lotus valve. Another unmet need is still the need for pacemaker implantation. And of course, it depends on the registry. Pacemaker implantation ranges below 10%, and in some series to more than 30%. We do believe that PPM is not linked to an increased mortality. The optimal range should be less than 10%, comparable to surgical aortic valve replacement. And of course, it's important for the health economy system to reduce costs and for the patient to prevent late outcomes. And if we shift TAVR to younger patients, to low-risk patients, maybe even more important to have a device with a low rate of pacemaker implantation. So these are again data from Ulm based on 216 patients with a Lotus valve implantation without a previous permanent pacemaker. And they see that the implantation depth is very important. So if we were able, or if we placed the Lotus valve in the range 0 to 4 millimeter below the aortic annulus, we had a pacemaker rate of 15 and 17%. But if we had to implant it deeper, for example, because we had a small distance to the coronary ostia, you see that there was a significant correlation and an increase in the need for pacemaker implantation. So the depth of implantation is important, and there are also some other data showing us that there is a low risk of permanent pacemaker implantation, 17%, if you are able to implant the device within the 0 to 2 millimeter below the annulus. Of course, if we talk about pacemaker implantation, it's not only the valve or the valve design. We have a lot of factors which interact with the need for permanent pacemaker implantation, like age, like calcification, like pre-existing conduction disturbances, AV block, and other factors. So durability in valve thrombosis is important for every valve type. And if we shift to younger patients and low-risk patients, we have to follow those patients for 10, 15 years. And we do hope that the TAVR devices will have similar outcome as compared to surgical aortic valve replacement. But we have to do those studies and include those patients in randomized trials and follow them very carefully to prove that the TAVR devices are durable. And if we look, and this is a slide from Martin Lyon, in the STS database, we see that the majority of patients undergoing aortic valve replacement are in the low-risk population, an STS score below 3%. And these data are again from Germany from 2014, and you see in the red curve that especially younger patients, the low-risk patients, underwent surgical aortic valve replacement as compared to the blue curve, which is the transfemoral TAVR group. And the working group around Professor Cook performed a propensity score matching out of these data and ended up with 800 patients having been treated with surgical aortic valve replacement and 800 patients having been treated with transfemoral TAVR with a logistic Euroscope below 10%. Which represents a low-risk group. And you see on the right side that in-hospital mortality was similar with 1.7 and 2.0%. And of course, there were some differences, as you can see here. So post-interventional respiratory problems were significant highly in those patients having been treated with surgical aortic valve replacement. On the other side, need for permanent pacemaker implantation was higher in the transfemoral group. But this is just an early picture. We do need randomized trials with a long-term follow-up to answer this question. So treating bicuspid anatomy is also always interesting, and of course we always need more data on this interesting anatomy. And there is some data with the Lotus device from the RESPOND registry, which were presented during PCR 2016. And you see that here 31 patients received the Lotus device in bicuspid aortic stenosis, compared to 965 patients treated with the Lotus in non-bicuspid aortic stenosis. And you see that the events were similar if we look at all-cause mortality or all-cause mortality and disabling stroke, if we look at major vascular complications, or if we look at newly implanted permanent pacemaker, it was even a little bit lower in bicuspid anatomy. So we do believe that the Lotus device is an excellent device for bicuspid anatomy. If we look at the risk of moderate or severe AR, it was in this small population group, 0% as compared to 0.3% in non-bicuspid aortic valve stenosis. So especially in the bicuspid anatomy, a fully repositionable device enables an optimal control of the valve positioning. You can put it out again, you know that from the Lotus device, and the Lotus Edge will also be, have these features, and we can control the post-implantation result. So dear Chairman, ladies and gentlemen, in summary, the present valve technologies do not perfectly address the needs we do have in TAVR technology, which is PVL, conduction disturbances, bicuspid anatomy, and of course the long-term durability. And the Boston Scientific Lotus Edge valve addresses those needs by use of a more flexible delivery system, having the same adaptive seal technology as the Lotus valve, being completely repositionable with an early valve function. We do not need pacing during implantation of this valve, and we have a very controlled positioning with a limited depth in the LVOT with a depth guard. We have a one view locking due to the additional radiopac markers and a reduced sheath size. Thank you very much for your attention.
Thank you, Jürgen. We're going to have the last talk, and then we have some time for discussion. So Mathias Göthberg from Lund in Sweden is going to tell us about his experience with the Lotus Edge system. Mathias, please.
Thank you very much. It's a pleasure to be here to present our data. The focus of my talk today is going to be our local Lotus valve experience, but also perhaps a little bit on pacing rate, which is obviously a focus on the Lotus valve. I'm also going to demonstrate a case of bicuspid physiology, which is really addressing to what Jochen Werle told about previously. And finally, also one slide about Lotus Edge Outcomes Registry, which is it's a national registry. So once we started implanting the Lotus valve in Lund, we prospectively collected all data of all implanted Lotus valves ever since we acquired CE mark. We used to be a low-volume center, but 65% of the patients who were treated at our center were treated with the Lotus valve since 2014 up until January 2017. In all, it was 177 patients. So the main limiting factors was the valve size. We're a Nordic population, so a significant amount of population needed a larger valve, but also peripheral access, especially before we had the bolt sheath. Out of 182 patients, 177 patients, we had successful access, delivery, deployment, and system retrieval. The main limiting factor was the severe tortuosity with an ability to cross to the aortic arch, but also one case where the 27 millimeter valve was too small and had to be exchanged for a 29 millimeter valve. And one early case, I think it was our third case overall, with a device failure where we had to exchange for another device. But it also, more importantly, really highlights the capabilities of this valve. We had no instances of obstruction, migration, embolization, ectopic valve deployment, or TAV and TAV deployment in this all-comers population. Patient outcome was also very good. Overall 30-day mortality below 3%. Disabling stroke rate is only 1.7%, but also low major vascular complication rate, of course, reflecting patient selection. So overall, in all our 177 patients, we have 14% pacing rates. When we started off back in 2013, we used a classic deployment technique, and that affected our pacing rate, which was about 18%. And then we decided to implant a bit more cranial, try to avoid LVOT interaction, and to reduce our pacing rates actually down to 8%. After that, in the last stratification, we introduced 2 more operators who were new to TAVI, but also started to learn with the depth guard system, which took a couple of implants before we learned how to optimize the implantation techniques. So went back up to 14% again. So from an international perspective, we have on the left-hand side the RESPOND, the Reprise 2 and extension trial, and the Reprise 3 trial, which has up to 30% new pacing rates. It probably reflects both the use of the classic implantation technique, but also a learning curve with the new technology. In Reprise 2, we only had 2 implants prior to randomization within the trial, and that probably, to a certain extent, reflects the higher pacing rates in the Reprise 3 trial. But also looking at the independent reported data from Berlin to the Swedish Heart Registry and our own experience, also Nicholas van Meegen has presented data, so ranging all from 12% up to 20%. So we do have favorable pacing rates, which are achievable using the current generation Lotus valve, the one previous to Edge, with increasing experience and modification of implantation technique. So we have the new kids on the block. This is Chris Madura and Vivek Rajagopal at Piedmont in Atlanta, 2 dear friends. They previously presented the impact on implantation technique on the pacing rates, which are data from the Reprise 3 and Reprise 3 continued access studies. These are the single center that was reported. And they used 3 different cohorts. First of all, they started off with traditional Lotus implant technique, which was proctored, which is a deep initial entry and landing at the radiopaque marker at mid-pigtail. And then they tried to go with a deep initial entry, but then drag it up to have a low final implantation depth. And then the last cohort, they tried to really avoid LVOT interaction overall, of course, without jeopardizing coronary access, which is important in these patients as well. So looking at that stratification, although not significant, there's definitely a strong trend towards significant reduction in pacing rates down to 12.5%. This is really something that mirrors our experience and other experiences as well. The modification of the implantation technique without jeopardizing coronary access can reduce your pacing rates down to acceptable levels. Also highlight the late-breaking trial, TAVR trial session today, where Chris Madura is presenting the impact of pacemaker implantation on clinical outcome from the Reprise 3 trial. So just going to highlight a little bit about Lotus Edge valve system. It has a lower catheter profile reduction together with the eye sleeve, which should really facilitate access, but also the increased flexibility, the one-view locker with radiopaque marker, which has really been one of the caveats of the current generation platform, because it's difficult to assess locking, but now it's really easy. But also the limited depth of implant using the depth guard technology, which was initially evaluated with the old system. Also want to show you a bicuspid case using Lotus Edge. I think it was our 2nd Lotus Edge case overall. It's an 85-year-old retired physician who has PMR, hypertension, good ejection fraction, but a very tight aortic stenosis with a peak rating of 125 millimeters mercury, a grade 2 AR, and some moderate pulmonary hypertension. So although it does not reflect in the SDS score, I think we can all say that this is a high-risk patient. So annulus of 421 millimeters, LVOT that reflects that, quite a generous SOV at 840 millimeters square. Good distance to the left and the right coordinates, which gives us a lot of leeway when we want to position the valve, and nice peripheral access as well. So when looking at the valve in itself, we did notice that it was a suspected fusion between the non-coronary and right coronary cusp, which would mean that this is a serious type 1 bicuspid valve, but also quite heavy calcification. So when you had grade 2 AR and a bicuspid valve, I think that we wanted to avoid doing a pre-dilatation. So we decided to use a 23 millimeter Lotus Edge valve with direct implantation. So notice here it's very easy to align the catheter and torquing it to align it into the aortic arch, but also significantly less force required to cross the aortic arch compared to previous generation device, which had a more stiff catheter. Then in terms of initial deployment, we had to balance the catheter. The reason was that there was not much annular anchoring due to the slight valve undersizing. So we created this small funnel high up in the LVOT, just trying to avoid expanding it too much in the LVOT, and just then applying a gentle pull on the catheter. and so followed by expansion of the valve. And then we centralized the catheter after the anchoring just to facilitate locking. And you can see the radiopaque markers here on the buckle and the post. And as I spoke, all three came together. So it's no lead assessment. Very easy to assess locking in a single view using fluoro only. This is the final result. This is not typically what you would see in a tricuspid disease, but it's quite prevalent in a bicuspid disease with a high final position where the valve anchoring occurs in the calcified leaflets and not in the annulus. The main difference is that you have more ventricular foreshortening than the usual case. Due to high anchoring, you probably need to start a little bit lower to facilitate the deployment process. But also a good end result with only trace PVL due to the use of the adaptive seal technology, which has been reflected by Jochen Werle before. And finally, we have an international registry, which is called LOTUS Edge All-Comers Registry, which will be available as soon as we have the valve available as well. So it's a prospective open-label registry, a national registry with 1,000 patients. And we're going to follow the patients up to a year, but the primary outcome is going to be the 30-day safety and efficacy measures according to VARC-2 criteria. So it's really an all-comers trial. So bicuspid disease, valve-in-valve, alternate access, we're going to measure it all. So if I may conclude, our own experience ranging from 2013 up to 2017 means that we have an excellent performance in a high-risk population with low mortality rate and low disabling stroke rate. Also not talked about too much today, we had an 87% absence of PVL, which really reflects what we've seen in the REPRISE 3 trial as well. Moreover, we had favorable pacemaker rates of 14% in 177 patients, despite implementation of the new technology and learning to adapt to that, and new TAVR operators. We also could see that in independent case series, the ability to achieve pacemaker rates well below 20% using the current generation Lotus valve. The Lotus Edge is a smaller, more flexible catheter with much improved visualization of locking, which I think will really highlight simplification of the procedure. Thank you very much.
Thanks, Matthias. So we have 5 minutes for question and discussion. So if you have any questions, please go to the microphone. I can start here asking you, Mike Reardon, as a surgeon. So we're talking about moving down to lower risk patients, but I'm sure we're also going to see we're going to move down to younger patients for TAVR, and we're going to see more of those patients having a bicuspid aortic valve. So what type of valve system should we look for? Can we use existing valve system which is designed for tricuspid aortic annulus, or do we need some which is special designed for bicuspid aortic valves?
Well, thanks, Lars. I think even the premise of your question, I think, is interesting because you said younger and low risk, and I think those are two different things. There are older, low-risk patients, and there are younger people that are low risk, and they're both really important things. And I think that although you can use everything in bicuspid valves, one of the nice things about the Lotus valve is before you're done, you know what you have. So in the other valves, you put them in, and you hope for the best. But once it's there, it is what it is. You don't have to let go of this valve until you're happy. And what we've found is that it's not always the calcium related to it or the anatomy of the bicuspid valve. It's where you land. And sometimes just going up or down a millimeter or two totally eliminates your leak. And you have that level of control to completely place the valve. And if you don't like it, move it a little bit, and you'll find out that often that makes a huge difference in the amount of leak you have.
I mean, the depth guard system you've been using and describing, does that lead to more repositionable situations that yes, because you have to aim a bit higher, or is that comparable to the classical valve?
I would say that we were struggling with the first cases because we didn't know how to implant with it. And as a result, we had a few more pacing. But once you got used to it, it took about 5 cases. It was actually easier to implant it and more predictable because you had less ventricular foreshortening, which otherwise is one of the limitations because you start off low and you end up pretty high. But with the depth guard, you have a much more predictable situation where you're going to end up in your final position.
Yeah, you know, I think it's going to be interesting when we roll depth guard out. I think the easiest people is going to be to teach are those that have never done a Lotus before, and the hardest ones are those that have done a lot of Lotus, because it is a new valve, and you're going to have to rethink the way you do things. And so I think that if you get new sites that are Lotus naive, it'll work really well for them. If you get new sites that aren't big TAVR implanters, it's going to be great for them because they always know what they have before they're done. And so for people that are learning, this is kind of the idiot-proof, you can't miss valve.
So there's been a lot of attention on paravalvular leak, and there's data supporting that if you have more than a mild paravalvular leak, it's bad for the outcome for the patients. So I'm going to go back again to, we're going to treat younger patients with longer life expectancy. Should we focus also on mild PVL, Ted? Do you think it's an innocent bystander?
I absolutely think we need to pay attention. It's just a matter of how long the Kaplan-Meier curve goes out. And when we're treating people who have an additional 20 or 25 or even 30 years life expectancy, I think we have to look at mild PVL very seriously. And the other thing, obviously, that we have to look at seriously in these younger patients with a longer life expectancy, is permanent pacing. And I think we're already starting to see, and let's say that all of the valves that are out there achieve whatever magic number we want for optimal pacing, it's still a problem. I'm starting to learn about placement of his bundle pacemaker leads for AV sequential pacing as a ventricular lead that doesn't cross the tricuspid valve. And the tricuspid valve is the whole issue here. I also think we can be optimistic that the so-called pill pacemaker battery life will start to become less of a problem for longer-term pacing. So I think that not only do we have to make our valves work better to minimize pacing, but we have to be more thoughtful about how we utilize pacemakers in these patients.
But is this maybe a trade-off, the pacemaker rate, as opposed to the paravalvular leakage? For example, the Lotus valve comes out with almost zero paravalvular leakage, has a bit more pacemaker rate. If you screw on one hand, maybe you increase it on the other side. What are the thoughts of the panel?
I think that's the trade-off we're looking at today, and that if we could implant a good biventricular pacemaker without crossing the tricuspid valve, we would agonize about it much less. And I think we know how to do that. It's a matter of developing our approach. The use of his bundle pacing is not new, and as I've started to learn more about it, I'm not understanding why it isn't utilized more.
So, Matthias, you and other sites have very low pacemaker rate with the Lotus valve, comparable to what you see on some of the other valve systems. How important do you think the indication for pacemaker is from site to site?
And how long do you wait, maybe also?
Well, first of all, we try to use the ESC guidelines for implanting pacemakers, and we do this assessment typically the day after. I think that if you do the assessment immediately post-procedure, you have a slightly higher pacing rate than you would do if you do have the assessment the day after. But we typically don't wait 2 or 3 days. So I saw the other session on TAVR complication and pacing that certain people lead in and do the assessment day 3 if you have prolongation of the QRS complex. But we typically do it at day 1. So I don't think that if you do the assessment day after the assessment, it means that you have a fairly low pacing rate. So I'd rather think that it has to do more with deployment strategies, the deployment techniques.
Is there any tendency for recovery? So what's a pacing rate of the systems once implanted over a year?
You know, that's something that has been hinted at in some retrospective follow-up studies, but in REPRISE 3 we have a prospective algorithm to assess pacing at several time points during the follow-up. So in the very near future we're going to actually have numbers, and it'll be for 2 different valve technologies. So I think it's going to be actually very powerful in helping us with some strategies.
Yeah, most of other trials, we of course have followed up how often you were pacing, but not how often you were pacer dependent. So nobody really did the turn down and the see. But I suspect you're going to find that 50% plus aren't being used at all.
Summarize the session here. So what you have seen is that the new Lotus Edge is building on the previously one. It's keeping some of the advantages, the adapted seal, the nitinol frame, the inter-annular position, and the early hemodynamic working valve. And it's also going to add some new features. First of all, it's coming with an eye sleeve, so it's going to be a 14 or 15 French, so it's going to address more patients with borderline vessel for transfemoral approach. It's also have this depth guard, which is going to have a more controlled deployment. It's not going to travel as deep into the left ventricular outflow tract, and thereby also hopefully minimize the conduction abnormality and the need for permanent pacemaker. The system is going to be much more flexible than the one you have today. It can take sharper angulation in the vascular system. And there's going to be added 2 more sizes, 21 and 29 millimeter. So it's going to address most patients for TAVR. Apart from the Lotus Edge, there's a next generation coming out, the Lotus Mantra, which have several features. First of all, it's going to be shorter, so you can plant even higher without having risk of coronary occlusion. And I think that's also going to be part of this to bring the pacemaker rate even further down. Boston is committed to do a lot of research in very different area here. You can see just a summary here. And so there will be a lot more data out how the Lotus valve is going to perform in different kind of patients. And just back to the pacemaker, for those of you who want to hear more, go to the session 5 o'clock in this room where you hear the late breaking on pacemaker in the Reprise 3 trial going to be presented by Dr. Chris Meduri. Boston also now have not only one valve, they have Accurate, which were formerly with Symmetries. So you have 2 valves. So you can now design or decide which valve site you're going to use for a specific patient. So even though you can probably treat 70-80% of your patient with any valve, you'll still have the last 20 or 30% where a specific valve is going to make a difference from the outcome. It can be access issue, anatomy such as bicuspid valve, heavily calcification in the aortic annulus, risk of conduction abnormality, low takeoff of the coronary arteries, and also the size of the annulus. So for those of you who want to hear more on the Accurate, you can stay here. In 5 minutes, the next symposium is going to start on the Accurate. So I'm going to thank George for co-chairing, Mike, Ted, George, and Matthias from the talks. Thanks a lot.